Good afternoon, and welcome to Navigating the Future of AI-Driven Patient Engagement, a health system CIO production sponsored by CTG. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You can send in your questions or comments at any time in the Q&A box. We'll take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 40 minutes with our main panel discussion featuring Chuck Christian, VP of Technology and CTO with Franciscan Health, Jeannette Currie, CIO at Cambridge Health Alliance, Beth Lindsay-Wood, Chief Informatics and Technology Officer with Moffitt Cancer Center, and Joseph Esdale, Managing Director, Cloud and Infrastructure with CTG. And then we will have our Q&A. So let's jump right in. We're going to have a fun discussion. Chuck, my old
Yes, sir.
friend, can you give us an overview of your organization and your role?
Sure, happy to. Thanks, Anthony. Thanks for the opportunity, and thanks to the rest of the panelists this afternoon. Chuck Christian, the Vice President of Technology and CTO for Franciscan Health. We're a 13-hospital system, mostly in Indiana. We do have one hospital in South suburban Chicago. Depending upon how you count them, 350 to 400 other locations, physician practices, urgent cares, imaging centers, lab draw, and I own all of the infrastructure for the organization. So I tell everybody, if it's broke, it's probably my fault.
Very good. All right, Beth.
Beth Lindsay-Wood. I'm the Chief Informatics and Technology Officer at Moffitt Cancer Center. That means that I have oversight to both the CIO or the IT group, our clinical informatics or health informatics group, as we're calling it, and our cybersecurity, along with our enterprise PMO and process excellence team. We are based out of Tampa, Florida, and the weather is warm. So just for those of you that aren't here. We have two hospitals. One was built about a year ago, but a very large ambulatory presence. A lot of our work is on the ambulatory side. So we're an NCI designated and NCCN cancer center, meaning we have a large research organization that works very collaboratively with our clinical teams, but also develops drugs, does a number of other things as well in that group. And we have an innovation and entrepreneurship arm, which is fairly new to the organization. Again, looking at partnerships outside globally for us. So those are kind of the key pieces of our structure.
Very good. Jeannette?
Good afternoon, everyone. I'm Jeannette Currie, Chief Information Officer for Cambridge Health Alliance. We are a health system just north of Boston and are very mission-driven, serving many underserved, providing the everyday healthcare that people need. So we've got two acute care community hospitals. We also have one full behavioral health inpatient facility serving geriatric, teen, and adult behavioral health needs. And then we've got a huge ambulatory footprint, again, focused on primary care, behavioral health, specialties that people need, even extending into dentistry.
Excellent. Very good. Joe?
All right. Thank you, everybody, for joining. And thank you also to the panelists who joined. CTGs, we've been in business for about 60 years. We have a healthcare vertical that has been around for about 35 years. We empower digital agility by delivering IT services and solutions that empower our clients to seize new opportunities and overcome challenges in this certainly ever-changing world. My role at CTG, I'm the managing director of our cloud and infrastructure team, and I've been with CTG for 9 years now.
All right. Very good, Joe. All right. Let's jump right in. Chuck, we're going to start with you. Where do you stand as far as leveraging AI in your patient engagement interactions? Sort of what progress have you made, and what are you looking to do in the near term?
Well, we're a Catholic healthcare system with a capital C. We are part of a order of none, so we're extremely risk averse from a legal and from a privacy standpoint. So we're very, very careful about what we do with PHI and other things. And so we're dipping our toe For us, AI lives in two different realms. One is clinical, and the other one is operational. And we haven't done a lot from the operational side of things. We're looking at a new call center technology that will have AI built into it. We've got a little AI built into ServiceNow for our internal call center stuff, but from a patient engagement standpoint, we're still in the IVR realm and not doing a lot of AI at this point in time.
Okay, very good. Beth?
We, again, being a research organization, we've been doing machine learning and AI in one part of our organization for quite a long time. But in terms of direct patient engagement, the areas that we're focusing right now are and have been is around the visit, and it's using virtual assistant or virtual scribe while the patient's in the room, ambient listening between the patient and the provider. Obviously patient consent for that, and we do a lot of work on the back end to validate the records that are developed from that into the system. So that's one area we've been working on and piloting several technologies for the last couple of years. I would say similar to Chuck, the use of a chat bot, because our patients are extremely sick usually. We have to be really careful about what we use it for. We are looking right now at piloting it for symptom management for patients under treatment that are at home. We have a partner that is going to help with some of that. But again, just probably not going to implement that for another couple of months. So we're not using it actively. So we're doing it in different ways. We kind of are looking at patient outcomes and some of those kinds of things separately, but direct communication with the patient right now is people, a little bit of IVR, those kinds of things for the most part.
All right, very good. Jeannette?
I'd say we're very similar in where we are in our AI journey. We treat a lot of patients who are not English as a first language, so actually are similar to what Beth highlighted with the ambient listening, where we're actually beyond pilot and moved into full rollout in a lot of our ambulatory clinics. And we're actually seeing it as huge benefit to the patient, because particularly when we have non-English speakers and we have an interpreter in the room, there's a lot of need to pick up on patient nuances, and having the clinician being able to look directly at, we've actually heard from our patients how beneficial that is, and how the eye contact and, not having to look at the screen is really benefiting them. We also have Jade Health, which does some translations of medical notes and instructions. So we're piloting with them to get some of our documentation translated into the languages that we see more frequently. And then we're looking in the near term to partner with Open Notes to actually do some work on patient-facing documentation as well.
All right, very good. So, Joe, what are your thoughts in terms of what you're hearing versus what you're hearing from a lot of your clients? So, are people reaching out to you sort of in an aspirational way, saying, we want to do more, we want to investigate this area? Or are you dealing with folks that are pretty far along here? Or are most people sort of in the same mode that I think we're hearing from all three of our other panelists? Joe, you got to get off mute, buddy.
All right,
There
sorry
you
about
go.
that.
Just start again.
Yep. So I think what we're seeing is everybody has been proceeding cautiously with this, especially when it's related to patient care. We've seen probably faster advancements with IVR in relating to interacting with your patients on the front end in their contact centers for the paying bills and scheduling appointments and things like that. For there, we're able to see customers that have leveraged the tool in order to drive down talk times, take care of tasks that are kind of considered toil and easy to do, and let their agents focus on the more complex tasks, the higher touch things, the ones that patients really feel that they need that human interaction for.
Joe, explain this to me. IVR, interactive voice response, right? Now, is sort of traditional IVR been around for a while and does not contain AI? and now we're talking about sort of infusing it with AI. Just take me through this. What does this mean?
Yeah, so I think IVR has kind of evolved into two phases. It used to be interactive voice response was just your menu options. Press 1 to talk to
Oh,
billing,
right.
press 2 to talk to scheduling. And truly it was an interactive voice response because you hit a number and you got to a spot. Now it's starting to evolve where it's understanding language. And you used to have to build your IVRs, so you needed a specific response for it to understand it, proceed with something like that. You used to be able to say, I want to schedule an appointment, and it had to be the word schedule an appointment. And
Right.
you had to think of everything. But now
Right.
with generative IVR, you can start saying, like, I need to see the doctor. And the generative IVR is able to look at its large language model and translate, even though the developer didn't build that phrase in, it understands that
Mm.
phrase and is able to get you in the right spot and reduce the frustration.
So that's really what we're talking about. We're talking about, as you said, the basic phase was press 1, then it was you had to get the phrase right. And I think that's probably one of the things that was the most frustrating to the users, because oftentimes it would say, didn't understand, say it again, and that's when you would get upset. And now with the infusion of sort of a Gen AI type component, you don't have to say the exact phrase. How good is that today? Sort of that natural language type of IVR to get you where you need to be, or the answers you're looking for, or do we still see a high degree of frustration with a lot of these things on the user end?
It really depends on how you build that interface, and if you allow for those not understanding. What I typically see is a good if you. I've seen the menus and I've been part of the menus where if you're not hitting, it just keeps asking you the exact same question and doesn't provide you any assistance, any help. We think a better design is if you've asked them once already and they repeat it, and you still don't understand it, that's where you can jump in and say, are you asking about this or that, and try to provide them some assistance to reduce that frustration.
All right, just want to follow up again, then we'll move on. You mentioned how you build it, and this is something I think we were going to address later, but to what degree can you customize and optimize these things, and to what degree do they come ready to use from the vendor, so to speak?
Oh, it's amazing. Like I said, you used to build these, and you had to think about every tree menu option you wanted to go through and every response. The generative AI build on IVR is amazing. You can give it in non-technical programming terms, like 6 to 8 commands on what you want it to do. Don't like we saw a nurse triage line while they're waiting on hold for a nurse, they could ask questions of the patient, give it directions, don't ask more than 7 questions, don't diagnose, and follow these protocols. And it will come back. And then that first experience with that patient while they're waiting on hold, anyways, is pretty amazing with some of the interactions and the ability for it to ask follow-up questions based on what the patient indicated their problem is. The follow-up questions are all relevant, and those weren't programmed in the IVR. Those were what it got from the large language model and whatever protocols you're following for the triage.
So the Gen AI and the AI makes it better product for the users, but it also makes it easier to customize and optimize for the health system.
Absolutely. You don't have to be a developer anymore. We see people in the call center managers who have no IT program working hand in hand with the telecom team to set up these IVRs. And pretty much the managers are now driving it, not the technical teams.
Yeah, so I feel like what we're going to be doing a lot of today is, Joe, I feel like you're going to be educating us on what's available, what's out there, what's possible, and what you recommend users investigate. Because sometimes you don't even know what's available. You don't realize that something is out in the market and available, and perhaps your vendor even has it available, but either they haven't let you know or you haven't taken the upgrade. So I just see that as being a good way to go today. Let's look at this question. Patients have abandoned IVR systems when they become frustrating. What are the key design principles or strategy that ensure AI-driven voice interactions remain intuitive and helpful? Let's take this to a higher level with the rest of our panel. And these were some questions I was going to get to later. But all our panelists are in charge of this kind of interaction that the patients are going to have with the technology. The goal is to reduce the burden on staff, to, to use technology to make things easier for the patient. One of the things I wanted to talk about was how you measure that, or how you keep an eye on that, figure out if something's working. So let's talk a little bit about that. Jeannette, let's start with you. How do you, as a CIO, as the IT executive, keep an eye on whether these things are working, or is that even your responsibility, or might that fall to an operational leader?
I think it does fall to an operational leader, but closely partnered, because we're tasked immediately with fixing it. When we look at this specific technology, we had actually, when I started, we were having massive issues with our phone system. And it was really threefold. It was lack of capacity, so people were calling to get an appointment and we didn't have them, so they were frustrated, from the get-go. Then it was we use interpreters very, very broadly, so we were getting drops in the midst of an interpreter call. And then to boot, we were understaffed in our call center. So it was like the trifecta of bad experience from the people who were calling. And that lifted up to our patient safety committee, to our quality committee, when we've worked tirelessly. And I see this as a fabulous adjunct technology to decant a little bit of these calls for the use cases that are appropriate, that the technology is ready to handle. In addition to, I talked about, how much we are non-first English language. And, we have considered making those prompts in our top 3 other languages. But the problem is, eventually, when you get to a human, they're an English speaker. So if we can get folks all the way through the transaction in their native language, that's going to be an incredible benefit to our patients.
All right, very good. Beth, your thoughts?
Unmute, Beth.
I was following Joseph.
Yeah.
Yeah, that was a joke. We'll call that the rest of the webinar.
Yeah. So I think that a lot of what you were saying, Joseph, is really important, which is the Gen AI component of this and how well it learns. And, from my perspective, it's targeting the right use cases for this for us, because there are some that are, at least out of the gate, probably easier for us to begin to use with less frustration on the part of our patients. So my concern, of course, is just that, we've got to be mindful of ensuring that we spend a lot of time testing these and having it continue to learn as we evolve some of these technologies, because we don't want. I mean, Gen AI is a wonderful thing, and I use it, but want to be careful about it, knowing what the boundaries are. And Joe, you made some great examples of how to use it. So that's something we just actually got approval for, an internal Gen AI platform that's kind of behind our firewall, so we can do some things without being out there putting stuff in places where we shouldn't. So I think that's going to be our opportunity to begin then to test some of these use cases and see which ones are the most successful, and certainly learning from others around us that are ahead of us a little bit on this.
Yeah, and Beth, you mentioned there's been 2 areas that sort of are emblematic of complexity. One would be acuity and complexity of the condition of the patient. You mentioned having cancer patients extremely complex. And the other was the languages that Jeanette mentioned, the language. And I've heard that, dialects and things like that can be challenging.
Yeah.
So, Joe, those are some things to consider. I mean, but every health system is going to have complicated patients, and almost every health system is going to have a lot of languages to deal with. And I suppose you want to do your best to accommodate those type of things. But maybe with the languages we top out at some point, we can provide some options and assistance, but it becomes unmanageable at some point. I don't know. Any thoughts there?
Yeah, so we were able to build a system. We had a client that large health system on the West Coast. They had 7 language. Their patient experience department said they needed to provide service in. So
Wow.
what we were able to do is put a front end menu that prompted for all 7 language for the very first thing. You know, if you want service in English, press 1, in their language. So I'll do Spanish and I'm going to stop there, but para servicio en español presete dos, you know, and all the way through Russian, Mandarin, things like that. And then we were able to program the IVR so that all the hold messages and everything like that were in their native language based on that prompt. You know, you can also do that. You can interface to the EHR and find out what that preference is. And if it's set, because based on the call-in phone number, I know it's this patient, and based on this patient, they've set it. We could then program to bypass that menu altogether and just start providing you your menus in your native language if it's one of those 7. And then beyond that, we would tell it, okay, if it's a more complex language, we're going to get an interpreter on the line to be with the agent. So the system would call out to the interpreting service saying we need somebody that speaks Spanish. When they're on the line, press 1. It joins the agent and the patient all at the same time so that the patient's first interaction is in their native language. When they're talking to a human, it's the interpreter saying, hey, I'm an interpreter. I'll be interpreting this for you. And then the system we use also has the ability, some more common language. There's a half a dozen that we don't even need an interpreter anymore. It listens to the conversation and it translates it for the agent. The agent speaks and then it translates it for the patient. So it's really come a long way in the last year.
So this is what I mean, Joe, about understanding the possible. And it's hard these days because things are changing so quickly that someone like yourself that's drilled into this area can keep up. But folks that have a wide purview of things they're supposed to be in charge of and technologies, it's hard. Um, so as a, you know, I don't know, what are your thoughts about it being incumbent on these vendors to reach out to at least their customers and say, hey, here's what we can do today without being annoying, right? Because you always feel like
Right.
if they're calling, they want to sell me something else. But the paradigm you just discussed sounds like it might be news to some people about what's possible. Do you agree with that? That not everybody may know that you can do everything you just described?
Really do, and I think you know with what we're going to see, and you know you hear this all the time with generative AI, it's going to change very fast
Yeah.
as we go forward. As other companies look to apply it to new ways and solve problems, there's going to be a lot out there. So you know certainly you know CTG does a lot of call center business, managed services for call centers and phone systems. So we do stay up on top of this, you know, and it's probably imperative to reach out to a trusted partner and ask them what's going on. And we certainly take it upon ourselves for our existing customers to make them aware of this technology during our client business reviews, find out what we talk to them about their strategic plans and find out how we can help with those strategic plans.
Chuck, what are your thoughts? Oh, go ahead. Whoever wants to jump in.
Real quick, I think
Yeah.
one of the other interesting things is that our partners, our EMR, ERP, those kinds of big platform partners are embedding a lot of Gen AI, particularly some other as well, but into their products.
Yeah.
So, you know, it's about whether you wait for that or if it's here today, implement that versus doing something internally as well. So I guess it depends on, you know, what your use cases are, but
Yeah, no, you're absolutely right, Beth. And that's, you know, one of the things that I've noticed is a lot of times when a health system will say they're doing AI, well, the question is it some sort of independent activity that you're doing or initiative? Or when you say you're doing AI, do you just mean your vendor rolled out the latest version and it's got AI built in and you're sort of leveraging that? So that's a great point. You know, but sometimes I guess it could be a product you're not even using, right? So you wouldn't be getting it through your vendor. Like the competitor to the vendor you're using has leapfrogged your vendor because they've made better use of AI. And although switching is a big deal usually, Chuck, How are you keeping up on all this stuff? How do people keep up? And you mentioned the element, there's a culture issue here because you mentioned your organization, somewhat risk averse. There's budget issues. So, some of the stuff can be compelling and some of it can be real and a real reason to move, but some of it is not being distracted by every bright, shiny object, as they say. How do you manage that as a technology executive today?
Well, I'm well trained as a big dog in a very small yard, and they keep throwing squirrels in for me to chase. The thing about it is that and our patient population is diverse as well, but it's also diverse from an age standpoint. We have to manage for convenience for the younger generations, like my children, and the old folks like me, who, and some are, don't like to talk to, that damn robot on the phone. And so, I think that looking at that and trying to get I was looking at a lot of these automated AI-driven IVR solutions. It's not easy to keep up because I just came back from HIMSS, and I actually started to go around, started counting all the booths that had, on the signage that had AI, but I quickly realized it's easier to count the ones that don't.
Uh-huh.
Because is it really AI? Is there a large language model behind it, or is it just machine learning, or is it just the RPA stuff? Everybody calls it all AI. So it's almost impossible to keep up. And so I learned from others that have been the icebreakers in the industry out there. I learned a long time ago that we really can't afford to be a pioneer. And those the pioneers get the arrows pretty quickly, and I've got a big enough target on my back. And trying to be a fast follower and trying to learn from the my peers in the industry about what are they doing, what's been successful. But we also too, you have to take in consideration what is going to integrate with everything you have in the platform. I own the enterprise architects in my organization, and we spend a lot of time of trying to figure out what fits within our infrastructure and our, the realm of possibilities.
Mm-hmm.
And so we're an Epic shop. And so, if it's not going to integrate well with Epic, or either have APIs that you can pull data from, because that's where all the patient data is going to live. And Epic is already, their CRM product is getting there. Is it perfect yet? No. It's kind of like back in the 90s and 2000s. There's still a lot of niche products out there that have got a lot of high-end functionality, but they have to stand alone.
Mm-hmm.
And so then you also have to worry about integrating with your phone system too. Lots of folks have voice over IP systems, but there's still those what I call the legacy warriors out there that still have PBXs. You still have to deal with some of the integration issues that go along with it. So it's paramount to impossible to keep up with everything that's going on out there. Just to put a finer point on your question. That's why I have no hair.
Yeah.
And
Yeah.
so
No, but what you said about being a fast follower, I mean, that makes a ton of sense. Let one of the academic medical centers, one of these cutting edge places, let them, prove out the use case with the technology, and then if we have the same use case, we can follow up pretty quickly, but we don't need to be the first. Is that kind of it, Chuck?
Well, yeah, but you also have to have a really good BS meter as well, is
Oh,
because that everybody's going to tell you they've got the best thing since sliced bread. And we've been, you and I both have been around long enough to realize that what you think is great and what's worked in one organization may not work well in another, because I don't know how many EMRs I've seen implemented really well in one organization, and you go and buy it and you bring it into your cultural and your strategy situation, and it's going to fail, because it's not about implementation, it's about adoption. And some organizations handle change management real well, and others just suck at it.
very good. Very good. All right. Let's go forward here. Reduce call center burn. Well, this is absolutely true, and this is what Chuck mentioned about the old folks. So, Jeanette, I see you laughing. I'm one of those old folks, and I get irritated very easily, and I am hitting 0 17 times and saying, "Speak to a representative. Speak to a representative." I may even start off with that because my confidence that I'm going to get where I need to go is limited. So if it's low, why even try? This is the problem, right? These kind of technologies have a large burden to overcome based on everyone's past experience. So you could be really killing it now, but you've got to get people to try again. Almost is the culture. So your thoughts on what Chuck mentioned about the different age populations? Certainly, older folks maybe have a less tolerance for this kind of interaction, and also always giving an out to "I've had enough. You don't understand what I'm saying. Let me speak to someone."
Yeah, I couldn't agree more. And I mean, particularly with deference to the Luddites in the crowd and in our population, we need to make sure that we've got a couple of that we've got a really easy transition to a human, because we never want to, we are patient facing, we are caregivers. It's a human to human interaction that makes everybody feel cared about. And I think that's why we focus so much on the right use cases. So, we never want to use AI to replace a human. We want to augment and make ourselves more operationally efficient, and, make our care provision even more patient focused. So let's just take the example of the call center that's overwhelmed. Maybe AI is really, really good at telling you if you have an appointment and where it is, but it isn't quite there to scheduling you. If we can decant even that small number of calls first and relieve some of the burden on our call centers and make us more efficient, what we have seen undoubtedly, and you even mentioned it, that you see companies that offer the same technology leapfrogging each other, but they all, the catch up seems to be really quickly. And we don't want to get into this pilot purgatory where you're trying something and you pilot it and then you hop to the next vendor because they're a little bit better, but then the original vendor kind of gets there in the eventual place. We want to get to a point of rolling out and actually leveraging the technology that we've invested in. So to that end, I think we're seeing the growth be so explosive that if we start somewhere, it will catch up, and we can help be development partners as well.
Good point, Beth. Your thoughts?
Well, I think I was reflecting a little bit, Anthony, on what you were saying, because as long as IVR is viewed by our patients and families that to be something that reduces a burden on us,
Yeah.
the less interested they're in participating. So it's very important, I think, that we make sure that what we're doing in that space is adding a lot of value to the patient and getting that feedback from them, instead of just thinking, great, we can cut another FTE in the call center. That's not, from our perspective, retention of patients, get acquisition and retention of patients, like any of us, is really important. And we don't want this to be a turnoff to people. And so I think, we have to be prepared. In our case, for a brand new patient that's interested in treatment, they've been recently diagnosed, we tend to be more on the people side. A nurse triage type person is a place that they can call, because that's an important first contact. I don't think IVR would be the best choice for that. But as we have existing patients or patients that want screening, second opinions, those kinds of things, I think there's places where this is very helpful, and helpful internally with cost reduction. But I think right now for us, we're real sensitive to the feedback we're getting when you're talking to a real provider, a nurse, or a nurse practitioner right out of the gate, to figure out what's the right next steps for you. So
Great point.
So Anthony, I'm going to jump in just a second. And I think the other thing is that where AI could play a decent role is not only in the the IVR piece, but my kids, myself. I mean, I use the technology. If I want to schedule an appointment with my primary care doc, I open up my phone and go into my chart. Is having AI on the back end, knowing who I am, and knowing that I've got my annual visit coming up, and when I open it up, want to schedule an appointment, go ahead and offers up some dates and times that my primary care doctor would be available. And so trying to ease that cognitive burden of waiting, what I call menu waiting, waiting through the various menus and clicking and stuff. If I tell it I want to do a primary care visit, it's my annual visit, it goes ahead and does it. So making it smarter and making an interaction with our patient populations less frictionless, or having less friction in getting it done. It's no different than prescription refills. I'll go into my chart and I know that I'm getting close, and it's already flagged the ones that it knows that I need to get refills. So all I got to do is click refill them, and I'm done. And then of course it knows that I have a copay and what that copay is, and so it just removes some of the cognitive burden off the people to get what they want to accomplish done.
Joe, what are you thinking about everything you're hearing? What's your reaction or thoughts?
I absolutely agree with all three of my panelists, and I had the exact same points down. What Beth said about making the IVR, you really want to serve your patients. If it's set up to really serve you and your agents and drive your total cost down, and as Beth said, try to get rid of costs by reducing agents, I think that becomes apparent to your patients, and they kind of balk at that. What Chuck was just saying about the anticipating the need. What I've seen is a lot of hospitals will have different numbers, so they don't have some have one number to go everywhere, but I've seen a lot where they have numbers published. If you want to schedule an appointment, call this number. For your prescription refills, call this number. You already have a pretty good idea why they're calling. And as Chuck said, you can dip into the patient record and say, hey, I noticed you have an appointment coming up next Tuesday. Are you calling about this appointment? And just narrowing down what their needs are and trying to make the experience pleasant for them, and not go through those voice menus hell we talked about earlier.
That's a great point. I think on the, if a patient's calling in to find out, for them to know, oh, I see you got this treatment yesterday. Are you having any symptoms or any, getting some of that on the front end is helpful for patients to guide them instead of going through a whole menu of options and those kinds of things too. There's a lot of other places on the front of the patient experience where we can apply AI, scheduling, some of those kind of algorithms, those kinds of things that make it easier to self-schedule. To Chuck's point too, is another place. It's not all just IVR.
All right, very good. This is, what Chuck touched on about the integration. AI-driven patient engagement systems rely on real-time access to EHR scheduling systems and billing platforms if they're going to be highly useful and provide a lot of relevant information. What are the biggest integration challenges and how are you solving them? So, Chuck, let's start with you on this. Are we making progress with FHIR and APIs and different kinds of standards for integration between systems between different vendors?
Well, thanks for giving me the easy one to start with.
Sure.
Well, I think that all the things you mentioned, the APIs, and I haven't seen too much on the FHIR is an API, so it may very well fall in that category. But a lot of the systems have made it easier to make it, and I'm going to use the word plug and play, which is terribly overused, but being able to plug into things. And if you don't have a solution that integrates with Epic, at least, if not Epic and Cerner and Meditech, you're not going to sell too many. And so I think that there is a deep focus on making sure that integration is there. And we've got a lot of standards. That's the good news. The bad news is we have a lot of standards. And so we just have to pick one. One of the things we're doing is, and have done, is put in an API management platform. And so we can know what data is coming in, what data is going out. So I think you have to plan for it. You have to build for it. You have to architect for it. And the fact is that I don't know of anybody that doesn't have I call them integration engines. The old term was interface engines, but with they still have to manage the APIs coming in, because if you don't, you could create data leaks and get yourself in hot water pretty quick.
Jeanette, what are your thoughts on that? Chuck used the term plan for it, build it, architect it. This goes back to one of the biggest issues in the industry right now, which is the dynamic of staying in suite, going with, if you're an Epic shop, going with everything Epic. When and how do you go out of suite based on user requests, something bubbling up from the business? This is what we want. This is what we want. Making those decisions, weighing the cost benefit. So your thoughts there?
Yeah, it's such a good question and such a balancing act. And, we set out with some guiding principles, and we really are trying to leverage our own technology first. We've made tremendous investments. We're a longtime Epic shop. We see the development that's coming down the platform, and they're a really good partner, inclusive of in the integration space. So it was interesting. I did spend the time walking the vendor hall at HIMSS last week and spoke to a lot of folks that were, entering or trying to sell us in the IVR space, and some were really focused on the AI portion of it. But I actually gravitated towards some that said, we started as an integration company, because if we don't integrate right, and again, get that patient experience all the way to the point where they have that effective appointment that they can show up for, or they get the outcome that they are looking for, we've failed. So I think a lot of work to do and to validate, and again, moving with that validation and that small approach as we look to scale is really important.
Yeah, that makes a lot of sense. Joe, where are we with these IVR tools? As far as you mentioned, a lot of integration points in terms of pulling from the EHR regarding the preferred language, being able to automatically identify these things. Um, so talk to me about that in light of what Chuck and Jeanette were saying about, you know, it's got to work well with my EMR. It's got to play nicely.
I think as a implementer of these systems, one of the first things we do is understand our client's environment. We don't want to propose another integration system if, as Chuck said, there's a lot of older interface engines, HL7s out there, things like that, that may already be able to fit that bill to provide the data to the IVR that it needs in order to provide a better patient experience. So I think understanding where your clients are and being able to help them build that roadmap of advancing this integration is probably the appropriate place to start.
Beth, thoughts on integration, staying in suite, not having a bunch of 6 zillion applications from 6 zillion vendors, and occasionally when you do have to say no.
Yeah, no, I'm a proponent for app rationalization and making sure that we're not bringing in technology just for technology's sake. But there are examples of when, if you want to be a little ahead of the curve, you may have to go outside of your primary vendors to get what you need. And it depends on what's important to the organization, strategically and operationally. But I will say, in my case, sadly, we have a 23 plus year history with our vendor, and it's been highly customized for us over the years. It also has a very odd encounter structure in there, so it creates a lot of difficulty in attaching other applications into that. So, I mean, we are looking at our EMR strategy, but counting on our vendor to be able to provide a lot of this on our current platform is probably not very realistic. So we do have to look outside in some cases for other technologies. But again, as we're looking at major investments in the organization that are going on, and our rising costs in IT as a result of cloud and even generative AI and some of the major compute that we do, it is incumbent on us to look for a way to solve problems with keeping in mind our costs. So just like everybody else.
Yep. All right, very good. Let's talk a little bit about the sort of compliance stuff. Beth, you mentioned, you get some cybersecurity responsibilities. What challenges do health systems face in ensuring AI-driven patient engagement tools, or any tools, align with HIPAA, CMS regulations, and other compliance requirements? There's a couple of links that are going to be sent out in the chat there, and that people will be able to click on the PDF, which they can access. So this is another issue. These are things that absolutely will become non-starters for folks like yourself, or deal breakers, or that kind of a thing. So, um, where are we with that, Joe? What do you know about this issue and things CIOs should keep in mind?
I think understanding those standards is certainly important, and I think all the CIOs do. But making sure that as you engage with another vendor, another partner, making sure that their developers are aware of the healthcare standards with HIPAA. A lot of times, I've seen developers come in who have no healthcare experience, and it's not even on their thought when they're architecting a solution in order to safeguard that data. So making sure you have a partner that's been in healthcare a little while and understand those standards, and helping you decide on the correct integration strategy that complies with those standards and meet those standards is I see an important step.
Chuck, any thoughts there?
Yeah, I got lots of thoughts. The thing is, you know that I have an opinion, and I'm not afraid to share it. The issue is that a lot of the large language models, they want to take your data and drop it into the language model so we can learn. Well, that's good news. But the bad news is once your data leaves your organization, you've lost control of it. And you're also still at risk if somebody else gets a hold of it and uses it for whatever reason. So I think that not only from the interoperability standpoint, and this is some of the discussions that we've had for years with the federal government. They want to free the data, but they also want to prosecute you and fine you when your data gets out and somebody gets a hold of it that shouldn't have it. So it's a balancing act and a double-edged sword about making the ease of access to the data, but also securing it so that you can still remain control of it. And I think that Beth mentioned that they're about to create their own large language model. I know a lot of organizations are doing that so they can containerize their own information and use it appropriately for these type of things. But the other thing too is that you lose the capability of the larger mass of data that's out there to help inform conversation, decision making, particularly on the medical side. And so I think that's where we're going to see a lot of the large language models are going to be, they're taking the patient identifiers out of it as much as they possibly can. So it can be used at a broader scale. Epic has that in Nebula, where they're taking the identifiers away from them, but using it in a much larger context. And so that's my biggest concern. And that's we have Microsoft comes out with a new Copilot every other day, and we haven't turned it on yet because even Microsoft will struggles a little bit on how to educate us on how we do appropriate data management. And that's the other thing that we haven't done a real good job of in healthcare. Everybody, pounds on us for because we're lagging behind in technology.
Right.
We're lagging behind on how we secure our data, but really and truly, we have lagged behind on, appropriate data management. And so we've got to do a better job of labeling that with sensitivity labels and that kind of stuff. So when we turn on these AIs, because AI is really good about finding things, and you want to make sure that people that are finding it, they should find it, and and it's appropriate, and the access appropriate. I don't know if you've ever dealt with an Active Directory, but somebody came up with a brilliant design to do nested AD groups, and it is you're chasing white rabbits down rabbit holes. So
Very good, Jeanette.
Yeah, I mean, talk about things that keep you up at night, right? I just keep saying to everybody, let's just stay out of the headlines here. So We're not in a position where we'd create our own large language model, but we would partner with MGB or with another area organization. But we've seen it already. We had the propagation of the chatbot. Somebody brought in a chatbot to a meeting to take notes because it was easier, and then all of a sudden it was at the next meeting, and had no guardrails. So to that end, we finally put in Gemini just to help and have a standard and block everything without people feeling like they were losing the efficiencies that these tools so clearly bring. But exactly to Chuck's point, we're still really working through how we would roll that out in a much larger scale, making sure that we've got the right policy. And we can't just rely on administrative safeguards here. We really need the technical ones
Right.
to exist, and we really need to understand them and implement them correctly. So there's just a lot of work to do here to safeguard all of our data.
Very good, Beth.
Yeah, I agree. I think our attempts right now, our current focus is to get this Gen AI platform up and running. We do have rather large language models that are in some cases shared data around genomics and those kinds of things that we can use. But I think for us right now, we have two paths, and one is to get that platform stood up and look for all the use cases, a lot of which frankly are in finance or rev cycle or other areas, not really patient specific on the Gen AI side, but also looking at our algorithm development. So we call it Moffitt AI because it's stuff that we're doing ourselves versus a vendor that might be sitting out there. Moffitt AI could also partner, a data partner or something like that. But working on those two things requires governance. And so we are putting in place, we have a patient AI governance group. They're looking at all of these kinds of requirements, but they're also looking at FDA and some of those kinds of things to make sure that we're appropriately assigning risk to different use cases that may come forward, and then looking at drift and bias and all those kinds of things for things that we're developing. So I think it's not just it's patient engagement, but it's more broadly the wave of AI has kind of crashed over all of us. It's a big part of our strategic plan. So, the expectation, my vertical in the strategic plan is called integrate transformative technology. It's not about the core, it's really about what are we going to do different in this space. So, we've got to get something going and in place and get moving on some of these things. And patient engagement is just one example, but we always proceed cautiously in the patient space.
It's so funny,
So,
Beth, right?
So Anthony, I mean to
Go
jump
ahead.
in again. Just
Yeah.
the other thing too is that AI is one of these things that doesn't have a hardcore return of investment.
Yeah.
Is that I don't know how y'all CFOs are, but mine requires that if we're going to drop in something new. And so we do a lot of proof of concepts and try to identify where is this actually going to create efficiencies, and where's it going to save us money? And there's a couple of different ways of counting that. I mean, I had a good friend, John Glasser, that I asked him once about how do you calculate that kind of stuff, and he looked at me and he said, well, because we were talking about clinical systems, and I think we can turn that into AI as well. Is he asked me a question. He said, so when was the last time that you did a return of investment on a parking lot if you're building a new hospital? I said, excuse me? He said, well, it's really not a return on investment. You damn well better have a parking lot for your patients and your customers to park. So, that's some of the same strategy we could use around AI, is that, it's going to be very, very difficult to identify that over the short term. It's going to take a longer term of investment, and it's like everything else. You have to manage it to success. And I think we're still in the shiny object phase of AI, I'm still waiting for this administration, even though they're kind of down on regulations, which I'm a fan of. I don't like a lot of regs either, but I think we're going to have to regulate this appropriately without penalizing those in healthcare, kind of like we currently do around security items.
I think there
Go
is
ahead,
a
Beth.
business case. I think there is a business case for a lot of this. I think initially it's more difficult and you have to kind of prove that it's true. But I think, we have in our case examples where we have one in production right now, an AI tool that is looking to manage denials in a way that will dramatically increase our revenue. I mean, not dramatically meaning billions of dollars, but millions. So I think we got to, we're putting it in, we're going to measure the results, but it's not a multi-million dollar solution either. It's a lower cost
Mm.
solution. Let's see what returns get generated from that. That's going to be what's going to get people engaged in using this technology. But again, using it with use cases that make sense. The Gen AI platform finance is coming forward to say, I will reduce FTEs and here's the reason why around using this technology. So I do think there are returns on investment. It's just in some cases it's early days, right? So we'll see.
Yeah, I'm just gonna. We have time for a final comment from Jeanette and then from Joe. I want to stick with this ROI concept. Certainly, the example Beth used is super concrete. I would even call that a hard ROI, reducing denials. I mean, that's not a tough one in terms of putting dollars with it. It's a little bit softer with helping clinicians you do their notes, although I don't, that's so logical and compelling to me that, but still, it's not quite the same connection on ROI. That could be more Chuck's example that John Glasser gave about the parking lot. It almost is going to be that any clinician is going to expect that when they come to practice. So they're going to say, where am I? You don't have this. I'm going to go send my patients to the other hospital where I'm affiliated. So your thoughts, Jeanette, around ROI, we'll make that your final comment.
Yeah, I know it's a great question. And actually, we did specifically, when we started our pilot in the ambient listening space, we did tie it to ROI, or at least to cost neutrality, because we said if you were going to use it, we would expect that you would see 2 more patients a week. And that about netted the cost of the platform. So now it's become a tool in the toolkit. And again, the immeasurable things like reducing burnout and all of these pieces that bring the joy back to medicine, hopefully, right? As we look at all of it. And I think this is the emerging technology that can do that, and you can't put a price on it. But if you start to quantify the turnover and the burnout and the extreme fatigue that we see, and start to do this really thoughtfully in a way that turns people's attention, I think there's immeasurable value in all of these pieces, as well as the true ROI. We're also looking at one that's just going to take our last year's worth of coding data and see where we potentially missed certain things. So again, I think there's a lot of examples of these real hard measurable ROI use cases that we shouldn't ignore.
Joe, we're going to give you the last word. We're about out of time. I'd like to frame it up this way. The IVR space, AI, that was really the focus of our talk today, or it should have been. We moved off a little bit, but we got to talk about what our folks want to talk about. So, but certainly that was a component of it. But for your final thought, let's get back to that focus. What do you want the CIOs, the IT executives to know about what's going on in this space?
I think one of the things that make this a risky investment for some CIOs is the fact that a lot of vendors out there are going to want to sign you to a 3-year contract. And how many people are you going to put on the system? And they want to license all the people that are going to use the system. And it makes it's not an easy ask to get into some of these systems just to do a pilot. I love what Beth said about, hey, we started in one area. The system we go with is Amazon Connect, and it's kind of revolutionary in its licensing model, where it's just pay for the use. You don't pay for people. Every time you just use the system, number of minutes in the IVR, or things like that, that's what you pay for. And if you don't like how something's going, you turn it off, and there's no long-term contract with it. So we've been able to drive those ROIs based on, hey, we think this is going to happen, and we turn it on, and we see how close we are to the mark, and we can either make tweaks or back out of it. But we get to kind of control that spend. It's operational spend, not capital spend, so it's easier to control. And if we're not seeing the return we want, we can turn it back off.
All right, very good. Well, as I said, that's about all we had time for today. Wonderful chat with our good friends regarding continuing education. You could use the final slide in the deck. If you'll get an email when the recording of this event is ready for viewing. If you want to reach out and work with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming panels. With that, I want to thank our wonderful panel, Chuck Christian, Beth Lindsay-Wood, Jeannette Currie, and Joe Esdale and CTG for making the event possible, and you for attending. And with that, everybody have a wonderful day.
Great.
Thank you.
Thanks, Anthony.
Thank
Everybody.
you.
Thanks, everybody.